Hello, it's me again. Today we will learn about the topic jaundice in newborns. What's wrong? Hope you can comment. Why is jaundice in babies so scary? Jaundice due to increased bilirubin, if not treated promptly, can lead to complications that seriously affect the child's development, such as when bilirubin enters the brain, it will show signs of acute encephalopathy due to bilirubin and nuclear jaundice. Acute encephalopathy due to bilirubin. Stage 1, 1 đến 2 days, poor feeding, lethargy, convulsions, hypotonia, in which poor feeding is the earliest symptom. Stage 2, middle of the first week, increase in somatotone, flexion, fever. Stage 3, after the first week, hyperthermia. If the child is given a timely blood transfusion in the very early stage, he or she can recover. In stage 2 and 3, the child may die. Nuclear jaundice, chronic and physical AE of bilirubin toxicity. Although at first it seems to be reversible and shows little abnormalities at 2 đến 3 months of age, but can many serious sequelae AE. First year, arching, stiffening, irregular movements and convulsions tend to reappear. In the high-end year, spasticity and convulsions decrease, but irregular, involuntary movements, rigidity or hypotonicity, will gradually increase. In the bother year, a complete neurological syndrome often appears, eschapism abnormalities, visual and auditory lesions, cognitive deficits, dental abnormalities. So why does high bilirubin show these symptoms? The toxic ability of bilirubin to cells, especially brain and body cells. When the bilirubin level is too high or the blood-brain barrier is damaged, the unbound free bilirubin circulating in the blood crosses this barrier, attaches to the membranes of body cells and causes toxicity. Damage at this molecular level is irreversible, despite treatment to reduce circulating bilirubin. The pathogenesis of bilirubin encephalopathy is multifactorial, including interactions between unbound free bilirubin levels, albumin binding, ability to cross the blood-brain barrier, and cellular vulnerability. So how much bilirubin will be toxic to the brain? The threshold for blood bilirubin that can be toxic to the brain is not possible to accurately predict this threshold for an individual infant, but the TP bilirubin threshold to identify 90% of neonates with bilirubin encephalopathy is 25.4 mg% in children with hemolytic disease, and 31.5 mg% in children without hemolytic disease. Premature infants are more susceptible to encephalopathy. Unbound bilirubin 10 đến 12 mg/dl may be associated with encephalopathy in some preterm infants. The longer the exposure time to high concentrations of bilirubin, the more rapidly the blood bilirubin increases, the more susceptible the child is to encephalopathy. Encephalopathy due to the dreaded increase in bilirubin can be prevented. Encephalopathy due to hyperbilirubinemia is preventable, but for prevention we should consider risk factors for hyperbilirubinemia. Risk factors for bilirubin encephalopathy. Immune hemolytic diseases, as mentioned. Bilirubin is a product of blood metabolism, so when the blood is hemolytic, the bilirubin will increase. Deficiency of G6PD enzyme leads to a deficiency of glutathione, an antioxidant capable of protecting red blood cell membranes against oxidizing agents in certain drugs, foods or infectious disease agents. If glutathione levels are depleted, enzymes and proteins are damaged by oxidation, leading to red blood cell dysfunction and rupture hemolysis. Prolonged hemolysis can lead to anemia. In addition, broken red blood cells also lead to the breakdown of hemoglobin in an excessive amount, which accumulates in the kidneys and leads to kidney failure. On the other hand, when red blood cells break down, they release free bilirubin into the blood. Newborns lacking G6PD enzyme will cause liver cell activity to decline, unable to metabolize bilirubin to excrete bilirubin, causing symptoms of jaundice and yellow eyes. Asphyxiation, sepsis, acidosis, Albumin 3.0mg trên dl, causing an increase in free bilirubin. Risk factors for hyperbilirubinemia. Low gestation and egg. Jaundice with indirect hyperbilirubinemia in neonates. Jaundice in the first 22 hours. Bili of blood trên bilibiform 15 in high risk trên HIGHINTERMEDIATE, Butani. Exclusive breastfeeding, especially if sucking is not good excessive weight loss. Other immune trên hemolytic disease, EG, G6PD deficiency. Yellow skin siblings. Granulous bone HEMANGIOMA trên brew. Eat Asian race. Causes of jaundice severe BX risk factors for severe jaundice. Above, research incompatibility sepsis. Lack of G6PD. Sepsis. Breast milk jaundice. Hypothyroidism, polycythemia vera, hematoma, breast milk jaundice, Gilbert syndrome, etc. Prevention of BILIRUBINCNS diseases. It is necessary to detect and promptly handle severe cases of hyperbilirubinemia with phototherapy before the child has neurological symptoms of bilirubin encephalopathy or requires a blood exchange. Our country does not have a well-developed family doctor system, nor medical staff to examine and take care of the health of mothers and babies after birth at home. Therefore, the decision whether to take the child with jaundice to the doctor or not, the time to go to the doctor depends on the mother and the young relatives. Therefore, the purpose of prevention is only achieved when there is close coordination between young relatives and medical staff at all levels of care and treatment, with the highest efficiency and acceptable cost. Avoid causing unnecessary anxiety and weight for young relatives. Necessary equipment for diagnosis and treatment is a must. Provide the community, in the antenatal and postnatal period, with knowledge on neonatal hyperbilirubinemia, bilirubin encephalopathy, and effective treatment measures. It should be confirmed that only two effective treatments, phototherapy and blood exchange, and soon exposure do not reduce jaundice. In the first days after birth, it is necessary to identify risk factors for severe jaundice, monitor children closely to detect severe jaundice. For mothers to successfully breastfeed their babies. Before the child is discharged from the hospital postpartum, the examination is recommended based on the risk factors for severe jaundice combined with the blood bilirubin level according to the Butani chart. The recommendation for follow-up examination must be based on the risk factors for severe jaundice combined with the clinical degree of jaundice Kramer. Therefore, it is necessary to guide relatives in detail and specifically how to assess the degree of jaundice BIs, in which the level of jaundice to the knee is often used as the time of follow-up examination. Our research published in 2014 shows that there are many barriers that prevent mothers from bringing their jaundice baby to follow-up appointments with medical staff, common among mothers and even obstetrician gynecologists. Custom stay in a dark room, abstain from leaving the house in the postpartum period. Jaundice is always physiological. Just take the baby to the doctor when the baby is sluggish or successfully. When the mother brings the baby jaundice to the doctor, medical staff assess the degree of jaundice clinical, and measure bilirubin through the skin and blood bilirubin if indicated, and refer to the upper level for timely treatment when severe jaundice. At the apply, do the necessary tests and treat accordingly. Children with severe jaundice requiring long-term follow-up for comprehensive developmental assessment, including hearing testing. Physiotherapy is needed when the child already has bilirubin encephalopathy. The examination should be based on clinical jaundice. Kramer, so. How is the blood bilirubin level determined? There are three methods of determining blood bilirubin levels. 1. Visual observation is the first method to detect jaundice and estimate the level of bilirubin in the blood, because the increased bilirubin in the blood will seep into the subcutaneous fat tissue according to the concentration gradient and make the skin yellow. Due to the physiological characteristics of the temperature and blood pH of the skin of the newborn, the yellow color of the skin will progress in the head body direction. Thus, it will begin first on the face and forehead, and then gradually down to the chin. To the tip, the higher the blood bilirubin, the lower the yellow color skin. Based on this feature, Kramer proposed the principle of yellowing visible skin to estimate blood bilirubin. The formula for estimating serum bilirubin according to Kramer, blood bilirubin mg% number of zones 1, 3. Mandatory conditions for evaluation. Bright white light source skin pressing to lose pink color of skin, head to toe direction. 2. Transdermal bilirubin measurement. Is the intermediate method between eye examination and blood test. Handheld, compact, simple to use. Principle of action. Bilirubin circulating in the blood diffuses to attack to subcutaneous fat tissue according to concentration gradients. So bilirubin in the skin can represent blood bilirubin. The light beam emitted by the machine when penetrating the skin will be partially absorbed by the yellow color of bilirubin in the subcutaneous tissue. The red will be reflected back to the probe of the machine, analyzed and given immediate results. 3. Measurement of bilirubin in the blood is the gold standard, indicated when yellow never. The degree of jaundice cannot be determined visually. Premature babies. Within 22 hours after stopping antipoison. When transdermal bilirubin 15mg%. In the first two cases, transcutaneous bilirubin measurement can be substituted.